that doesn't feel good to say one thing and hear someone say it back to you and then they do the complete opposite. Like, they did not respect you in that moment. And I genuinely apologize because that is not okay.
All right, so I've done the absolute worst job ever on this rotation, psychiatry, which is the last rotation I've never seen before, of updating y'all on my day-to-day, what's going on, how things are going. And I don't know. I'm gonna do better. I only have 4 more shifts. Crazy to say or odd to think, because I remember my first day and saying like, oh, this is gonna be a 6-week rotation, and here we are already at the end. But let's just jump into all of it, okay? Hey y'all, welcome back to Madeittomedicine with Vicks. That's me. I'm a 3rd-year medical student at the University of Illinois College of Medicine. Come to you semi-weekly, talking to you about my pre-med term med school life, a little bit of everything in between. Currently on my psychiatry rotation, almost done, and I've seen things from patients who are actually psychotic or like in psychosis to bipolar disorder, antisocial disorder. So a lot of personality disorders, schizoaffective, depressive type, I think it's psychotic type or manic type, bipolar disorder, a patient that I believe has schizophrenia and with active psychosis. I've had people first day chase me down the hallway to that same patient being discharged, and that being a whole little thread of things as well, because like the discharge, if that patient was so psychotic that they were chasing us down the hall and like punching the doctor in the face, that also turned into like the discharge was a lot. Like, we had one paramedic team try to discharge them and they were very combative, and so didn't like that day for some reason were not really agreeable to males. And one of the paramedics was a man, and the woman was like, look, I don't feel safe transporting this patient by myself. So then another paramedic team had to come. All that to say, my anxiety had increased, my cortisol levels raised, because I'm still like terrified. But also I've had patients with major depressive disorder, general anxiety disorder, like so many things. So I want to talk diagnoses and treatment with y'all, and how I have interacted with these patients on a day-to-day, and questions that have to be asked daily during interviews to assess cognition, alertness, orientation, all of that. But it's very windy as I'm on my way to a doctor's appointment, or as I'm out and about in the city, because it's a semi-nice day. Still a little cold, got this coat on, but I took off my scarf at least. But anyway, we'll get into it momentarily. All right, I currently have 3 patients, and one is getting discharged today. So I didn't have to see them this morning because they like really want to be discharged. Spoke to the attending, spoke to social work. So I'm going to work on the 2 notes that I did work on, or of the 2 patients I did see today, and I'll have to write a discharge summary in addition to us having 2 new patients. So it means 2 new interviews, which make the morning so long. And I have a meeting at 1 o'clock. So I have a lot to do, but we're gonna get it done. And also here we don't have Epic Chat, so I have to like open up Teams, Microsoft Teams, and that's how we discuss patients. All right, we have just finished rounds, and although we have a couple of new patients, we're not going to take them there on the attendings team. So I'm working on my notes from this morning from seeing my patients, and then I have to write a discharge summary for the patient that I did not get to see, but they were definitely fixated on being discharged. So it was a little high stress or high, they're emotions were heightened. So it was best that I didn't see them. And they also, when I interviewed them, I always stand in a position where I'm to remain safe, but they get a little bit too close in my bubble where I don't feel as safe. So didn't mind not seeing them this morning. Packed my lunch, set it on my coffee table, left it at home. I have a meeting at 1 o'clock, so it's in a little over 2 hours. So I'm trying to get through all of my notes and then head out. Have an OSCE today as well. So yeah, a lot of things. Placing my first consult order.
Every single morning when I see my patients, I always ask them, so how's your mood? Because this is like the first way that we open up every single soap note. Patient states their mood is, and you quote it, I feel great, or amazing, I feel very down. Whatever it is, you state that. Then you, if it's something really bad or abnormal, there's a follow-up question. Oh, well, why are you feeling this way? Did something happen last night? Did you not get enough rest last night? Or actually, I don't even try to prime them. I just ask why. Why do you feel that way? And let them explain. Because as I was talking to our resident yesterday, it was the whole, you don't want to put words into someone's mouth and just let them articulate their feelings, their goals, aspirations, whatever's on their mind today. And then I ask specific questions to patients. So like, are you having chest pain, shortness of breath, lightheadedness, dizziness, if my patient has COPD or if they have heart failure, right? Because I need to see if they're in an exacerbation. If they are in their COPD, when was the last time you had your inhaler? So I started asking that in the beginning, and then I realized, like, girl, you are at the end of third year, you know how to go to their chart and check their meds. Check to see when was the last time they had their inhaler. And then the other standard questions are, have you had thoughts to harm yourself or anyone else? So we're asking about suicidality or homicidality. And then, are you hearing or seeing things that others are not? We're asking about auditory or visual hallucinations, which could be a sign of psychosis or schizophrenia or an unspecified psychotic disorder, or it could be bipolar disorder with psychotic features. So essentially, I need to know like what realm, to what degree is your capacity. And I also ask the alert and orientation questions. What's your name? What's the location of where we are? And what is today's date? And in the chart, when I document these things, I have to be specific. Saying person, place, and time is fine. But if they say the year, but they don't have the month and the day right, then I'll just say person, place, and year. Or if they get the month right, but not the day, just want to be as specific as possible in the notes. And at the end, since we are a goal-oriented program, what are your goals for today? Like, what are you working on? Because this is not just a psychiatric floor where, we're keeping people locked up because they are dangerous to themselves and society. No, we know that everyone has varying abilities, capabilities, and mental statuses, but wherever you are, how can we assist you? So those are some things I ask every single day. Some of the wildest things I've seen, one patient, it was during an admission, my colleague was admitting them. And so as a medical student on the team, when you're admitting a patient, you have to do the initial interview. So the overnight team brings them in. So no one on my team has actually seen the patient before, unless they've been previously admitted. But this admission, we need to know, like, okay, in your own words, what brings you here? And one patient was like, I'm homeless. I need a place to stay. And they were like, oh, so like, how are you feeling? Would you say that you're depressed? And they took this very long pause and said, if you were homeless, wouldn't you be depressed too? And I was like, well, the gag is, you ain't wrong. And I had to let my colleague know, like, you did a great job handling that interview, because I would have been so choked up, like, you write that question, probably want a good one. But as students, we're so focused on getting through our checklist, right? Like, I'm not an experienced psychiatrist. I'm not going to be a psychiatrist, although no matter what field you go into, maybe not pathology or radiology, but you need to have a basic knowledge of psychiatry, because like, we're engaging with people and you need to be able to engage with them and have like this conversation. So the goal of it is, like, most people are admitted due to SI or HI, and we want to know, like, why? Are there any life stressors that got you here? Like, if you are unhoused, or as we both learned, is undomiciled is another way to say unhoused or homeless. Where have you been staying? Are there any other life stressors that have led to or contributed to your current mood? When was the last time you followed up with the doctor if they have like some type of mental illness or mental condition or medical conditions that have not been cared for in a while? When was the last time you took your medications? Like, all these different things. And another time, when we were sitting in the room and interviewing a patient, I was asking all of the questions, right? And I pride myself on being able to read the room. Like, I know if you're not vibing with me. I know if you are vibing with me, like, I know to keep going with the banter or to just kind of step away. I had a patient where I'm asking all these questions, like, because it was, to me, I was trying to determine whether it's schizophrenia versus bipolar disorder. So for mania versus bipolar disorder, there's the acronym DIG FAST. So distractibility, impulsivity, or decreased interest. And DIG is grandiosity. F is flight of ideas. A is increased activity. S is decreased sleep. And T, talkative, pressured with your speech, and kind of like flight of ideas when we go back up to the F. So I'm asking all the questions for a bipolar disorder. And I asked one thing, and the patient just stopped and looked at me, and I'm just like, and they said, well, something, 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 do you understand? But they didn't answer my question. So I asked again, and they were like, do you understand what I'm saying? Do you comprehend? I said, actually, I don't. That's why I'm asking you to rephrase it, reword it, because I'm really trying to understand you, and I want to make sure that I'm doing a proper assessment and meeting your needs as best as I can. And right now I'm not doing that. And I could see them kind of get like frustrated, but then they did further explain. And there was some mistrust with the medical system. And honestly, rightfully so, especially in my opinion with psychiatry patients, people kind of like ignore them, or don't think that, they either don't think that they're being honest about their illness, or they think that since they have an illness that they can't make decisions for themselves, or every decision that they make is wrong, and they essentially take away their autonomy. And I don't think that that's right either. Like, I don't agree with that. And so when they were explaining something where medical providers essentially did not listen to them and remove their autonomy, I said, I apologize for that, because that doesn't feel good to say one thing and hear someone say it back to you, and then they do the complete opposite. Like, they did not respect you in that moment. And I genuinely apologize, because that is not okay. And they were like, don't say you apologize if you don't mean it. I was like, honestly, I do. Because I can't even imagine going somewhere and someone doing something to me that I didn't ask for and that I didn't give consent for. Like, that's not okay. And I truly empathize with you. And once I showed my humanity, I feel like that is when they kind of let their guard down some. And they were answering my questions like yes or no, and also providing more details instead of being more guarded. So like, overall, psychiatry is a very interesting field. And I do think that I learned a lot, but also it can be very easy to become jaded in this specialty, because you do see so many people, and there are some who definitely try to like work the system, and then there are others who truly need your assistance. But at the end of the day, I'm like, if someone's trying to work the system or beat the system, they need your assistance too, but probably just in a different way. And at the very beginning of this rotation, I likely said this on Instagram on one of my posts, I was like, I hate the way that veterans are abused and mistreated. People know that they are receiving government funds and government assistance, and a lot of them have substance use disorders, whether it is cocaine, heroin, crack, cannabis. Like, they have all of these different substance use disorders, and so people in their communities prey on them because they know that they're going to get this check. They know they get this fixed income, and some of them it's lofty amounts of money. And although the VA is set up very, very well, where we have these residential programs if you want help with substance use, or if you want assistance with like coping strategies or coping mechanisms and tools for your mental illness, we have those. Or we have like outpatient residential homes that we can refer you to. They just have so much access, and you don't have to pay for anything as a veteran. But I don't like how people are abusing them outside, which can lead to paranoia when you are admitted to a hospital voluntarily or involuntarily. And it has definitely made me decrease judgment. Like, I know everyone loves to say like, oh, I'm not judgmental. No, everyone has some level of judgment. And I am now a lot more receptive and a lot more open, because you couldn't even imagine some of the patients that I've encountered or interacted with. But I try my hardest to see their humanity, to see their humanness, and to understand that a lot of times people have just been dealt a sucky deck of cards. Like, you have a sucky hand, and it's not your fault. But how can I assist you with whatever goals that you're setting out for today and get you moving on to progress? You know, like I told a patient today, the only moment that we can control is the one right now. We can't do anything about what happened in the past, and we can hope to live to see the future. But right now is all that we have. And so, like, what can we do in this moment right now to be better? Remember that it's a marathon. And when you run your first marathon, that is your personal record, because it's your first one. And the next one, you get better at it. You start having different goals to assess where you want to be. So I feel like, although I was talking to them and sometimes using like therapeutic language that I've learned or gathered from being in therapy, and it works and it's helpful. So yeah, I know I said I was going to talk about the different disorders and like the diagnoses and the treatment. I'll do another one of those in my study vlog. But I will say, for schizophrenia, you should have 2 of the things on the list, which are like delusions, hallucinations, which is visual or auditory, so seeing or hearing things that others are not. And I always get schizophrenia mixed up. Negative symptoms are like flat affect, so not showing mood like expression. So I could be talking to you the whole time like this, and I'm telling you a very emotional story, but I cannot, or I refuse to heighten my emotion. Like there's a lack of fluctuance there. We already went through bipolar. There's definitely something I'm missing for schizophrenia, but you treat them with antipsychotic medications, which could be haloperidol, risperidone, clonazepam, aripiprazole. Bipolar disorder you treat with, first line is lithium or valproate. You can also do lamotrigine. If they're having psychotic features, you would add on quetiapine. Definitely never, ever, 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 ever give someone who has bipolar disorder an SSRI, because that can increase their, or lead them to mania, which is basically behaviors that are not exhibiting of their normal selves or their baseline, and they could get violent or just very, very like up. And I think in last week's video, or my most recent video, I talked about things that are treated with SSRIs. That's a serotonin receptor, serum serotonin reuptake inhibitor. That's general anxiety disorder, depression, Tourette's, I believe panic disorder. You can also treat I want to say anorexia with an SSRI. Clearly, I need to go back and study. There's something to treat bupropion. Bupropion is used to treat something, and I always forget it. Need to finish reviewing my practice exam. And for alcohol use disorder, you can give naltrexone or buprenorphine. Knowing your mechanism of actions for all of your medications, very, very important. Since I've done neurology already, they definitely pop up like Parkinson's and Alzheimer's disease, knowing that mechanism of action for the medications and what like neurotransmitters are down in those different conditions. So yeah, I definitely have my work cut out for me, but I learned a lot. I have learned so much, and now I have 3 days left, and we gonna rock it out. The goal is still to honor. I'm going to ask one of the attendings next week if they'll write me a letter of recommendation for residency, because I do think that I have shown significant growth from the beginning of the clerkship, and I've been able to show my personality, and they've seen me conduct multiple interviews with patients, and I've done a better job of coming up with a plan for them. So I'm excited for that, and excited to move forward to surgery, as this week is Jesus week, it's Holy Week. And the sermon this morning, it was joy and pain. So I have so much joy that I'm finally coming to the end of my 3rd year of medical school, which essentially I've been in medical school for 4 years. But I'm still in my 3rd year because it was extended due to step 1 and now surgery, repeat. But the pain of it was the repeating, having to repeat surgery. It was having to take step 1 2 times, having to get a new neuropsych evaluation so that I could submit that and get testing accommodations for step 1, and starting medication for ADHD, being Vyvanse 30 milligrams once a day, and sometimes adding on a little bit of Adderall, which is only 10 milligrams, because depending on what's going on, I'm overstimulated, I'm overwhelmed. But I had to go through that pain to get to where I'm right now. Like, although this road has not been straight for me, I'm straight, I'm good. Like, y'all, this now is real, because I am closer now than I've ever been before to being Dr. Vicks. And for that, I give God all the glory, the honor, and the praise, and I am nothing but a grateful child. I'll see y'all in the next video. Bye.